Patients with severe asthma and COPD often continue to lose lung function despite receiving maximum doses of corticosteroids. Standard anti-inflammatory therapy reaches its limit. These patients frequently report zero symptoms of chronic coughing and produce no sputum. There is no external signal their airways are physically obstructed. While the patient's exterior appears stable, their internal physiology tells a different story. Clinical tests show a collapse in forced expiratory volume and a dangerous increase in residual air trapped deep within the lungs. This lack of outward symptoms left the medical community unaware of a massive invisible obstruction developing in the lower bronchopulmonary segments. Evidence of the obstruction only emerged through high-resolution CT lung imaging, which allowed researchers to see past the clinical presentation. In these transverse and coronal panels, distinct bright opacities reveal solid tubular structures, completely occluding the airways. These plugs can persist for years without causing visible tissue collapse. Researchers now use a segment-based scoring system to quantify these hidden occlusions. This data from the COPD gene cohort links the presence of these plugs to a significant spike in all-cause mortality. Patients with plugs in 3 or more segments face a much higher probability of death and a drastically increased risk of severe respiratory exacerbations. These structures act as immobile anchors in the airway, physically preventing gas exchange and accelerating the decline of the lung. To understand how a protective fluid becomes a dangerous solid, we have to look at the cellular environment of the airway wall. Normal airway mucus is a soft, mobile hydrogel. It is designed to be transported by the mucociliary escalator to clear debris from the lungs. But in severe disease, a flood of inflammatory cells creates an environment of extreme oxidative stress. This triggers a biological transformation similar to a blood clot. The mucus undergoes a rapid phase change, hardening into a rigid, immobile mass. Protective mucin proteins, specifically MUC5AC, are chemically tethered together by the surrounding inflammation. The result is a total mechanical failure. The airway is attempting to move a solid object using biological systems built for liquid. Rheology provides the proof. This chart shows the elastic modulus, or solid resistance, spiking upward in asthmatic mucus, while viscous liquid flow remains low. Oxidation drives this, forging unbreakable disulfide bonds between mucin polymers. These links create a permanent molecular grid. This rigid structure immobilizes the gel. Instead of gripping and moving the mucus, the underlying cilia simply slip against its hardened surface. This process creates distinct physical shapes, which researchers categorize by length. In this 3D rendering, you can see the difference between short, stubby plugs and long, branching, stringy formations. The stringy phenotypes are particularly dangerous, as they correlate with the highest total volumes of mucus and the fastest loss of lung function over time. Traditional hydration therapies and bronchodilators fail because they cannot overcome the physical rigidity and structural integrity of these chemically cross-linked masses. The physical stiffness of the plug creates a self-sustaining microenvironment, or niche, that is isolated from the rest of the lung. Within this niche, normal immune responses fail to resolve the obstruction. Infiltrating cells cannot digest the rigid structure, leading to years of stagnation in the same airway. Standard treatments ignore this structural reality, failing to address the covalent bonds that keep the plug anchored in place. Effective treatment requires a direct intervention to dismantle the plug's molecular architecture. To restore airflow, we must target the specific chemical bonds that maintain the plug's rigidity. Thiol-based reducing agents provide the solution. These compounds are designed specifically to cleave the disulfide bonds that hold the mucin grid together. When these bonds are severed, the solid mass reverts into a liquid gel. This allows the airway's natural mucociliary escalator to finally transport and clear the obstruction. By applying the principles of biophysics, we are moving from managing symptoms to physically unblocking the airways, restoring the breath of millions living with severe respiratory disease.